Good morning, good day, good afternoon, good evening to everyone joining our webinar on diabetes and sexuality. Welcome to all of you. Can I have the next slide? I first of all would like to thank the organizers of the webinars. We have our webinar chair, Patricia Pascual, and she is together with the Education Committee planning our monthly webinars. And I want to welcome all of you being here, both members and non-members. For those of you who might not know the ISSM, my name is Annamaria Giraldi. I'm the current president of the society. And the ISSM has a vision that every human being has the right to a healthy and satisfying sexual life. The next slide. We also have a mission and a purpose. And just to give you a little background, the International Society of Sexual Medicine was founded in 1982. And it develops from being a society dealing with males' erectile function to be a society that deals with the whole field of human sexuality. And it is our mission to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange worldwide. And I think these webinars are really a good example of how we try to fulfill this mission. We have more than 100 people already joining the webinar, and they are from all over the world, and we expect more people to join us within the next minutes. Next slide, please. So ISSM is built on our regional societies, and this is just to show those of you who have not participated before that we have regional societies that you might consider joining in both North America, South America, the Middle East region, Europe, the Asian Pacific region, and the South Asian region. So wherever you are in the world, there will be a society that, a regional society that you can join. And we are also affiliated with the International Society for the Study of Women's Sexual Health with a specific focus on women's sexuality. So the next slide. If you're a member, we have a lot of benefits. You could see it in the introduction. One of the really benefits are that we have 4 journals. We have our Journal of Sexual Medicine Open Access, and Sexual Medicine Reviews. And we also have our video journal of prosthetic surgery, which you have access to as a member of our society, where you can get access to the most updated research in our field. The next slide. So we have a very busy program, so it is a great pleasure to introduce the moderator of this webinar, Burnett. Bud is the Patrick Wallace Distinguished Professor of Urology at the Johns Hopkins University School of Medicine, where he specializes in sexual medicine, in mating pelvic reconstruction, and the management of cancer of the genitalia and lower urinary tract, including prostate cancer. He has been and is still very active in both national and international organizations in urology and sexual medicine, and has been in this field for more than 30 years. And among some of the roles he has in his professional life is that he's the past president of the Sexual Medicine Society of North America, and he's also, which I'm very pleased to be working with him, as his treasurer of our International Society of Sexual Medicine. So welcome, Bud, and thank you for taking your time in your very busy schedule to moderate this session.
Yes, thank you very much, Annamaria, and certainly it's a delight to be part of this program today. I think we're all in for a treat, and I'm very honored and privileged to serve as the moderator for this ISSM webinar on diabetes and sexuality. I'd like to just review with you briefly what our program is all about. The program is set up to involve presentations. We have 3 outstanding leaders and contributors in the field of sexual medicine to present for you today on this topic. This will be followed afterwards, after the presentations are delivered, with a Q&A session. And this will go on for approximately 30 minutes. As you can see, the program is listed. Dr. Yacov Reisman will speak on the impact of type 1 diabetes on young people's sexuality. Lisa Vicente will speak about what we know and what we do not know about the impact of diabetes on women's sexual response. And then we also have Dr. Giovanni Corona speaking on long-term effects of diabetes on sexuality. So with the Q&A session, please know that we want you to utilize the Q&A button This will help us be more complete and deliberate about responding to the questions that come through. So please, as participants in the program here today, please utilize that as how we'll go about the Q&A session. And that will be right after the presentations are delivered. So I'd like first to introduce the first speaker, a good friend, Yacov Reisman. Yacov is a urologist and a certified sexologist. He's a well-recognized leader with expertise in sexual medicine. He's the medical director of Flair Health Amstelveen, a program director of sexology at Rhino Amsterdam, co-director of the ISSM School of Sexual Medicine, honorary and visiting professor of andrology at the Federal Institute of Urology, Moscow, and Jiao Tong University, Shanghai. He is a past president of the ISSM. I'm very delighted and honored to present to you Dr. Reisman. Please deliver your presentation. We look forward to your knowledge. Thank you.
Thank you, Bud. Thank you, Bud. Good day to all the listeners on the other side that I'm not able, unfortunately, to see. And next slide, please. I don't have any conflict of interest for this presentation, so next slide, please. Let's start on. I will focus only on young people and mainly on diabetes type 1. So before we start to talk about diabetes and the sexual consequences, we certainly need to understand what we're talking about adolescents and young adults. And in that case, according to the World Health Organization, they define adolescents between the 10 and the 19 years. But actually, we don't need to talk about age because it's quite a diverse group with tremendous changes in physical, psychological, and social issues. So we look at the person and not only on the age. When we talk about young adults, according to the World Health Organization, we talk about a group of people between 19 and 30 years old. But just to keep in context of these things, when we talk about sex urge, the first kiss, at least in Western countries, Western Europe, is between the 13 and 15 years old. And on average, the first sexual experience is when they are 17.6 years old. Next slide, please. And in the period of adolescence and become a young adult, actually, they need to develop a lot of assets in becoming an adult. And they need to develop competence to specific things, to develop confidence, and this is certainly important for their sexuality, have connection with other people, with other institutions, their own character, sense of right and wrong, caring for other people. And for those issues, they need information, they need to develop skills, they need a safe and supporting environment, which is not always available, unfortunately, but this is certainly important. And as healthcare professionals, they need to have the availability of health and counseling services. But you see how many things they need in that period, and all of these are important for their sexual health and could be impacted by chronic disease as diabetes. Next slide, please. So diabetes type 1, just for in general information, there are different prevalence of diabetes in different countries. In the Netherlands is about 9%, while in some countries is even as high as 50%. But in all of them, actually more or less 10% of all diabetes patients are type 1. And the expectation is that it will increase in the next couple of years tremendously, and even more for diabetes type 2. So we need to be aware of it. Next one, please. But having a diabetes, certainly type 1, have tremendous physical consequences, psychological consequences, and influence on sexual function. Just look about the fact that from the moment that they get a diagnosis, they will need to change their lifestyle, to change their diet. They need a lot of self-control on therapy and the use of the therapy. And this will impact their body image, their self-esteem, their identity, the way they cope with these issues. And we know that there is increased prevalence of depression and anxiety in those group of people. even eating disorders. And nowadays we have a new term called diabetes burnout. They are fed up of all the measurements that they need to take in their daily life. On the same time, this social environment should be important in their support and the way they react, because those young people are living in a social society. They have sexual activities. They have adherence to some institutions. They want to get relationship, and even with the parents, there are issues. You know that in adolescence, this is tremendous important. So you see that all those things can influence on their sexual well-being. Next, please. What we know in the literature, and I must say that concerning diabetes type 1, we are limited in scientific evidence and scientific studies. We know that there is increase on erectile dysfunction, and some reports are going as up as 50% of the diabetes. They are earlier than other age group in their ED. They are less responsive to the PDE5 inhibitors, but there is less clear relationship related to the diabetic control, the glycemic control. And that's totally different from the diabetes type 2. The IAF is correlating with age, with the BMI, and the back depression index. And there is certainly association with depression. There are some studies claiming that premature ejaculation is more prevalent in diabetes patients, but actually the prevalence is comparable with the same age group in match control. So that's not important issues, but the PED questionnaire correlated with age and again with depression questionnaires. So for us as a healthcare professional, whenever they are coming to us with sexual dysfunction, we certainly need to pay attention to the psychological factors as well. Next slide, please. How about testosterone? You will hear in a few minutes from Giovanni Corona about the relationship of diabetes 2 and testosterone. In the case of diabetes type 1, there is clearly less correlation, as you see on the figure on the left side. What we find very well is that there is a relationship between BMI and free testosterone, even in the type 1 diabetes. Next slide. What about the females? Certainly underestimated, limited studies, even less than for the male. We do know that there is relationship, we do know that according to the FSI measurement, the prevalence of sexual dysfunction is between the 27 and 35%, and in the general population of match age, in few studies that done, you see that it's only 50%. Lubrication, mainly arousal and pain, sexual pain, are significantly higher in the diabetes type 1 population. There is no clear association with age, with the duration of diabetes, BMI, the HbA1c at cutoff of 7%. But again, there is clear association with depression, with anxiety, and the quality of the relationship. So the psychological factors are predominant in both sexes, mainly in the female, and we do know from studies that the females are willing to talk about their sexual problems, but they want to do it with a trained and knowledge healthcare professional, which means that we need to put investment in the education of the healthcare professional about sexual dysfunction in general and in diabetes as well. Next slide, please. What are the risk factors for sexual dysfunction in diabetes? Less acceptance of the disease, negative attitude for the treatment. So the people who don't accept the chronic condition and the recommendation, there is relationship with glycemic control when the HbA1c is higher than 8%, and with recurrent urine tract infection, lower FSFI, and again, depression and anxiety. The one who are physically active and have acceptance of the disease have less sexual pain in general. Next, please. New coming modern issue is technology. And technology is there also in diabetes, and we have two issues that are very prevalent, the subcutaneous insulin infusion and the continuous glucose monitoring. Very important. Unfortunately, only 50% of the diabetes type 1 patients use those technologies. And when you ask them why they prefer not to use that, you see that sexuality is an important reason. For the people who use it as well, almost half of them say that it's to interfere with sex. It's getting in the way, it's interrupting the moment. Some saying I look like a robot, and majority of them disconnect the pump during sex, and that's a risk for hypoglycemic issues. And the main reason is the discomfort, and this is also the main reason for to choose a location. There is no difference in sexual behavior concern age of intercourse, number of partner, frequency, satisfaction between the user or not user of the technology. Next slide, please. And the hypoglycemic episodes are the main issue for the majority of them. I'm doing in the Netherlands regularly meetings for answering questions to young people with diabetes. And this is a study from Israel, and I found almost the same percentage of results. 40% of them report some occasional mild hypoglycemic events, while 35% of them have fear of these events during sex, and they experience more mild events. They are often singles and have higher anxiety scales, which is obvious. Surprisingly, 60% of them don't take any measurement to prevent the hypoglycemic event during sex. And measurement that you can advise them is decrease the dose of the insulin. Certainly, if it's on the pump, take care that you have some dextro energy tablets or snacks available next to you, and repeat measurement before and after sexual activity. Despite those facts, 90% of them not avoiding sex, which is great, and 80% not avoiding use of alcohol before sex. As you may know, use of alcohol increases the risk of hypoglycemic crisis. Next, please. What about the relationship? Actually, luckily, majority of them reveal the issue of diabetes between the first month of the relationship. They also said that good quality intimate relationship are actually important for the general health, for the physical health, the psychological health, but also in the compliance with the measurement for the diabetes treatment. But don't forget the partner. Despite the fact that there are some issues for the patients, 30% of the partner experience some distress on hypoglycemia, and majority of them don't get any information and are not involved in the treatment. And that's a very important issue to remember. Next, please. The parents are also there, and they are worried about the control, about unplanned pregnancy, and they are afraid to discuss the sexual and reproductive health issue. So we need to help them on that as well. Next, please. What about sexual minority? I mean, the LGBTQ plus group. We don't have almost any information about it. There is one nice study who showed that when they are on the sexual minority during adolescence and early adulthood, they have increased chance of diabetes. How come? We don't know exactly. The theory is about minority stress. So keep it in mind that they are at risk. Next slide, please. What about education? If you look at the guidelines on education to diabetes patients, the young ones, you see that it's all about disease, vulnerability, glycemic control. Nothing is there about sexuality. And this is our responsibility of healthcare professionals, and keep that in mind. Next, please. This study done by the group of Patricia Pascual, our webinar editor, which is an excellent qualitative study who look at the impact of the disease on the sexual and reproductive health. And it's really crucial that hypoglycemia during sexual activity is an issue, the use of the insulin pump and the monitoring is an issue, and the interconnection with other individuals. This is critical. Self-disclosure is an issue. The fear of being rejected in a new relationship is an issue for majority of them. On the same time, partner knowledge is very important to them. It's part of love and caring for each other, and this have impact on their management of the diabetes. Next, please. In this study, they looked at the relationship adjustment. As you see, the self-disclosure and the partner involvement on the same time is an important issue of the majority of them. The knowledge need is more instrumental. They want to know what to do with a simple situation and simple solutions, but they want also to understand those solutions. And the same go for the sexual health and the sexual experience. Next slide. I don't have all the time to explore the whole study, but if you have the opportunity to read it, do that, because they put some great tables with all the factors that people ask about, and it can give you things to thought about and to give the information to your patient if you manage with them. Next, please. Last but not least, contraception. We know that pregnancy in adolescents and young adults have worse outcome comparing to adults with diabetes. So to give the right information to plan it to avoid the unintended pregnancy is very important. So we need to give sexual education at the beginning of the puberty, use this opportunity to include lifestyle and sexuality. Which type of contraception is effective? As you see on the diagram, the implants and the uterine device, the long term, are the most recommended also on guidelines. They are most reliable. In early age, they were worried about the pills, the oral contraceptive that will affect glucose level. But if they are in low dose, there is no problem with it. There is risk of the IUD for pelvic infection. So if there is recurrent urine tract infection, take care of that. And remember that there is no problem concerning the progesterone only related to gain of weight. Next slide, please. I will skip this slide because it gave an opportunity what needs to be done in the education of the adolescents in terms of coping, accepting the new normal, and also don't forget the parents in their reaction. They will be able to impact the way the adolescents deal with it. Next slide, please. What I want to say that when they come to us, give psychoeducation, promote their autonomy. It's very important to them as in all adolescents, promote social contact and give sex education as for everyone. Be aware that diabetic patients have issues with self-image and confidence, and we need to support it as well. Involve the partner when there is a partner in the young adults and adolescents. Give them the knowledge and involvement in treatment because it will help the patient as well. And use practical tips. That's what they are looking for. Next, please. So my take-home message, remember that diabetes has tremendous impact on them and also possible on the sexual development and autonomy. Having a chronic disease have consequence on sexuality and relationship, and our intervention going to knowledge, compliance, and sexual health in first intention, but be practical with them and boost their confidence. Thank you very much. If there will be questions that will not be answered at the end of the webinar, you can use the question and answer, but also mail to us as well. Thank you.
Well, thank you very much, Dr. Reisman. That was very informative. I think we learned a lot, and we're going to move along with the program. Just again, for the Q&A session, just as mentioned, that will be a session after all the presenters deliver their talks. Please, as a reminder, when you use the system, the Q&A button, please also be sure to indicate who you are directing the question to. which speaker, so we can make sure that we get the most direct response to your question being asked. So I'd like to move on now to our next presentation, what we know and what we don't know about the impact of diabetes on women's sexual response. Lisa Vicente, and I'd like to give you an introduction. Dr. Vicente is a consultant, gynecologist, and obstetrician with postgraduate specialty training and has expertise then in sexual medicine, responsible for the reproductive healthcare outpatient clinic at the Portuguese Diabetes Association, which she has done since 2003, past 20 years or so. She's a board member of clinical sexology competence of the Portuguese Board of Physicians from 2016 to 2021, expert consultant and national representative in the development of the Action Plan for Sexual and Reproductive Health towards achieving the 2030 Agenda for Sustainable Development in Europe in conjunction with the World Health Organization Regional Office for Europe, and that was in 2016. She is a member of the board of the Portuguese Clinical Sexology Society and of the Portuguese Society of Andrology, Sexual Medicine, and Reproduction. I'm sure we're in for a treat, but Dr. Vicente, please proceed. We look forward to your talk.
Thank you. I'm really thankful for the invitation. I'm very happy to be here and to speak about female sexual and diabetes, because when I began, and the Portuguese Diabetic Association is a healthcare unit that has all specialties. And so when I began in 2003, when I went to big Congress, I had to explain, because everybody says it was not real, that women with diabetes, like men with diabetes, could have sexual dysfunction. And so for me, listening to you and reviewing all these statements, it's a lifetime of working with women with diabetes. And so the first slide, I think that Dr. Reisman made my talk much easier, because he already explained many topics and many issues that I was thinking of speaking. But so I will concentrate on something a little bit different. For us who work with people with diabetes, it is very classical to believe that this is a lesion, this is a disease that has endothelial lesion. So we always speak about vasculopathy, small and large arteries, and also of lesion of autonomic nervous system. And for us who take care of people with diabetes, this is the same for both sex. And so it was supposed that you could expect that from the physiological point of view on sexuality, that the alterations that we saw during the phase of excitement, arousal, would be very impacted by this lesion, endothelial lesion, and with the autonomic neuropathy. And so, next slide. You can go on. This should be saying what we know about women. What we know about women is much less than we know about men most of the time. But we know that during arousal, it is supposed to have an increased blood flow around vagina and the clitoris tissue. And there is the process of vasocongestion, relaxation of smooth muscle, and a transudate during the capillary endothelium, which is sensed for women as lubrication. And for us, although there is no erection, because there is no albuginia that contains all this alteration, the fact as we imagine that this endothelial lesion and the autonomic lesion could have an impact on the feeling of being arousal. And the next slide. I always say, I introduce you to the most unknown part of our body, which is clitoris. Clitoris, which a neurologist Ellen O'Connell in 2005, after many studies, anatomical studies, image studies, could demonstrate in a long article that the clitoris was just not the little button that you see in most biological or anatomic books. It has really demonstrated that there are a lot of tissues that surround the vagina and that get the same process as it occurs in the penis during the phase of arousal. And so it is very important, and many times this is forgotten. For instance, and making a small question, how many men will try a penetration, any kind of penetration, vaginal, anal, without erection? Probably no one. But how many women try vaginal intercourse without completely being arousal? And probably a lot of them. And physically, the mechanism is the same. You need lubrication, you need to have all this engorgement to feel what Ellen Land spoke as pelvic airbag, to feel okay with your intercourse. Next slide. So we know that clinical risk factors for men and women, they are correlated with the most serious complications on diabetes. So older age, long duration of diabetes, long duration of bad control, and untreated hypertension, being obese, don't work a lot on exercise, smoking, they all correlate with the gravity of, or the severity of the lesions, microvascular and macrovascular, cardiovascular disease. And until now, most of the studies will correlate that also with sexual dysfunction. But this is the very interesting point. This is not obvious from the studies with women with sexual dysfunction and diabetes. This correlation is not clear. Why? Next slide. We know, and we have some studies, we don't have a lot of studies, and the biggest problem is that we have studies with small numbers. We have studies with different classification for sexual dysfunction because it has changed along the time. And so sometimes it's difficult to collect. Dr. Reisman showed very different numbers on dysfunction, sexual dysfunction in women with diabetes. But we know, and it is clear that sexual dysfunction is clearly more frequent in women with diabetes than on women without diabetes. And I chose, because I could choose a lot of things, but I chose to bring you this data from the latest study published already this year. That's the miles, diabetes miles. There was a first one in Australia. This one is for Flanders, and showed that type 1 diabetes, women with type 1 diabetes reported this sexual dysfunction, sometimes a long life, 36%. A lower number of women with type 2 diabetes reported sexual dysfunction. And I think this is the most challenging aspect, and probably we can go on discuss this on question and answers. you could expect the most prevalent report would be for arousal, but it isn't. It is for desire. Most women who complain about sexual dysfunction complain about desire for type 1 and for type 2 more than arousal. And that we can do it for a discussion, because probably most of the time women don't acknowledge their problem on arousal, but they really feel that if something doesn't work, they have less motivation for engaging in new relations, and so they perceive it as less desire. Next slide. And what we know, Dr. Reisman already spoke about this, and yes, depression is the most, and since the first studies by Enslin in 2003, depression was the risk factor most associated with sexual dysfunction in women. I think it is increasing also in men, but that's not what I'm speaking about women. And also this question, the feeling of well-being, the feeling okay with your disease, because it is true. People with a chronic disease have to adapt to the reality of what you have to do daily. You must admit that you have a chronic disease. And then with diabetes has, at least in Portugal, diabetes has a very hard social perception as a severe disease that you can get blind, that you get to hemodialysis, and so it is very difficult to receive this notice when you're young, or even when you're not so much young. And it is also associated with more anxiety symptoms. And so even in 2003, 2004, and most recently, these were the risk factors that were more frequently associated with women who had sexual dysfunction. Next slide. But of course, that there are not many studies. There are studies from Slope back in before 2000, and then Winsky, and this one from Stephanie Booth, and trying to look if it is a vascular disease, why you should have something on women with diabetes that would change. And so this is a very interesting study that access vaginal blood flow, clitoris sensitivity, and then another question, subjective sexual arousal. And what is astonishing is that this study could not find any difference between women with diabetes and women without diabetes controls on vaginal blood flow, on clitoris sensitivity, and subjective arousal. Although, and this comes sometimes in some studies, even with Enslin in 2009, if you look for women with complications with retinopathy, you would have a lower basal vaginal blood flow. Or with women with neuropathy, there was a reduced clitoris sensitivity between, if you compare women with diabetes with complications and women with diabetes with no complications. But curiously, there was no association with weaker feelings of sexual arousal or genital sensation. What is said, there are other studies like with Ellen Land and Van Loosen and other groups that show that there is a poor correlation between what is biological arousal and what is a sense, that sense of arousal, a subjective arousal for these women. Although they conclude that this could be something that converse and has some adverse effect on physiological response, sexual response, but it was not obvious that these were responsible, the only responsible for the cause of sexual dysfunction in women with diabetes. Another one. So I think that we all agree that the fact that you have to adapt to a new disease, and the study from Patricia Pasquale that Dr. Reisman presented, it is a very important document that shows that it interferes with all your life. And if you care with women that have diabetes, they always say it. They are always saying it. Some just say that they don't have diabetes, some just don't disclose that. But, next slide. I think that there is a new challenge, because I think that as a doctors, we can a little bit more on, we always say as a doctor that diabetes is a silent disease, because you could not say anything about it. So nowadays, you have to do a coming out. This is very curious, because we spoke about diabetes distress and how to deal with diabetes, but you must think that you must also say, I have diabetes. And when you put pumps in, when you have continuous glucose monitoring, you are showing society that you have diabetes and you have to deal with it. And so it's really a coming out as we speak for other things. Next slide. So taking home message, yes, it is real. And I always say that diabetes, it's a very democratic issue, a disease, because you have people from different ages, different religions, they have also different diseases, but they have also different gender, different sexual preference. And so we must address these issues when you are on consultation. And to remember that although I had to concentrate on diabetes and sexual dysfunction, that I also see women that have sexual dysfunction like pelvic pain, genital pain, penetration, vaginismus, alteration after abuse, that have nothing to do with diabetes, and they should be treated as accordingly and not because only explained because they have diabetes. And to remember that there are a lot of studies that show that everyone in consultation would like that the professional would initiate the talking about sex and sexual difficulties or sexual dysfunctions, because sometimes there are not dysfunctions but difficulties. And it is easier if you ask for something and you, as we say in Portugal, you open a door so they can expose their doubts and their difficulties. And so this information should be always on information to people with diabetes. And the last take-home message, next slide. Practical issues. Yes, it is very frequent that they refer, especially younger people or people who have diabetes for a short time. Because when you have for a long time, well, most people really adapt and go on sexual activity with higher levels of glycemia and trying to snack more or to give less insulin. And for the pumps, yes, you must give active information. You ask, how do you deal with it? Because it is possible to stop the pump for a while and to have sex, and then to see how your glycemia is, and then to correct as accordingly. But it is important to speak about it, because sometimes people know and already have information on that, because here the groups on diabetes, they tell each other a lot of information, but some don't have that information, and so it is important that we give it. And contraception is obviously very important, and because many times, not here for diabetes, but for every chronic disease, sometimes doctors are afraid to give contraception because of the disease, but it's right the opposite. If you have a disease and it impacts in problems during pregnancy, it is very important that you have safe contraception, and it is possible to have. And something that we spoke a lot of on depression, and it's very frequent that women have medication on depression, for depression, which impacts mostly on desire, and they forget to say it. It is important to discuss or to write to the colleague who is prescribing the medication that you could find a new formulation that impacts less on desire. And so I always speak about sex-friendly therapeutics, because there are nowadays medication which is less impacting on desire. And so I try to keep on my 10 minutes. If you want to have questions, I will be, of course, ready for the question and answer. Thank you.
Thank you very much, Dr. Vicente. That was a wonderful presentation. We're going to move right along. Again, questions from the audience, use the Q&A button and be sure you direct your question specifically naming the speaker you'd like to respond. We are now going to move on now to Dr. Giovanni Corona, and again, another wonderful contributor and leader in our field. By brief introduction, he is an endocrinologist and andrologist at the endocrinology unit of Maggiore Bologna Hospital in Bologna, Italy. He received his MD degree at the University of Bologna and the board in endocrinology, and the Doctor of Philosophy degree at the University of Florence. He has received several prestigious awards. He's quite prolific, and he is a co-author of more than 400, that's right, 400 peer-reviewed manuscripts, as well as book chapters, invited reviews in the field of endocrinology and sexual medicine. In 2022, he's nominated as the president-elect of the European Society for Sexual Medicine. So we look forward to his leadership there. He's going to give us a talk on long-term effects of diabetes on sexuality. Dear Dr. Corona, please proceed.
So thank you, Bud, for this kind presentation. If I can have the first slide. First of all, I'd like to thank the ISSM, all the organizers of this webinar, for the invitation. I will talk especially on type 2 diabetes, as Kobe said, and focusing my presentation on erectile dysfunction. Then if there will be possibility, we can discuss other issue during the discussion. So what about preclinical medical conditions? So next slide, please. This is a paper that we published some years ago in Journal of Sexual Medicines by analyzing preclinical and clinical glucose abnormalities. As you can see, in a large series of patients seeking medical care for sexual dysfunction, about half of them presented an impaired fasting glucose or diabetes mellitus. And in particular, look at the yellow bar. So in 2% of the cases, we were able to diagnose newly, so not known diabetes mellitus. So next slide. As you can see, the worse metabolic control, so from normal glucose valus, fasting glucose valus below 100 milligram per deciliter, to impaired fasting glucose with two different cutoff, 101, 100 and 110, and 110 and 125 milligram per deciliter, to newly diagnosed or established, so type 2 diabetes diagnosis since a long time. There was a worse sexual function, so higher prevalence of severe ED, high prevalence of the reduction in sleep-related erection, reduced prevalence of sexual intercourse, as well as the reduction of premature ejaculation. Next slide, please. In addition, as expected, the worse metabolic control, the worse penile Doppler ultrasound parameters, so meaning anorganic and mainly organic problems related to sexual function. So higher prevalence of pathological peak systolic velocity or a combination of peak systolic velocity and impaired resistance index at penile Doppler ultrasound, as well as the reduction of peak systolic velocity after PGA1 stimulation of penile Doppler ultrasound. Next slide, please. In addition, just using a risk engine to evaluate the risk of forthcoming development type 2 diabetes, this is called atherosclerosis risk in community, ARIC, by looking just at the risk factors, so the risk for development type 2 diabetes. Next slide, please. Which includes several items, including age, parental history of diabetes, fasting glucose, blood pressures, waist circumference, and lipid profile. So next slide, please. So the higher score of this risk engine, again, the higher risk of worse sexual function, higher risk of severe ED, higher risk of the reduction of sleep-related erection, reduction of frequencies intercourse, as well as masturbation, and also a higher risk of induratio penis plastica, which is well-known type 2 diabetes risk factor for EPP. So next slide, please. Similar to what observed for fasting glucose, again, the higher score, the worse penile Doppler ultrasound parameters evaluated in flushed conditions, so before PGA1 stimulation, and in dynamic condition after PGA1 stimulation. Next slide, please. So we can conclude that for sure that pre-diabetic conditions are tightly associated with erectile dysfunction. Next slide, please. In addition, we also found, as Kobe already said, that the worse metabolic control, so the worse metabolic profile, the lower total testosterone and calculated free testosterone, even after the adjustment for confounding factors. So the higher risk of hypogonadism, considering different cutoff, 10.4 nanomolar, 12 nanomolar, or 8 nanomolar, and also the higher presence of hypogonadism-related symptoms as detected by higher androtest score, which is an index that we previously published and validated, essentially summarizing the presence of hypogonadism-related symptoms. Next slide, please. Similar to, again, to what observed for the association with sexual dysfunction, again, the higher score in ARIC questionnaires, so the lower total testosterone, calculated free testosterone, and no modification of LH. This was also seen for type 2 diabetes. I will show you thereafter, suggesting the presence of secondary hypogonadism, or at least a mixed hypogonadism underlying the conditions. Next slides, please. So pre-diabetic conditions are for sure associated with erectile dysfunction and hypogonadism. Next slide, please. In addition, in a subset of our patients, 1,000 and more than 600 people, we collected, after mean follow-up of 4.3 years, the incidence of major adverse cardiovascular events, including ischemic heart disease, other heart disease, sudden death for cardiac disease, cerebrovascular disease, as well as peripheral arterial diseases. Next, please. So overall, we found 8% of major adverse cardiovascular events, which were essentially, in vast majority of the cases, an ischemic heart attack, and 11% were fatal. Next, please. By looking at the association between the fasting glucose levels and the incidence of MACE, we found, as derived for Kaplan-Meier, that either the incidence of MACE and specifically the incidence of cerebrovascular events were associated with impaired fasting glucose, but by adjusting the data in the Cox regression models, we found that especially the incidence of cerebrovascular events were tightly associated with impaired fasting glucose. Next, please. Similar, again, by using ARIC algorithm, we found that in the whole population, and even after excluding the people with diabetes in the population, even after adjusting for confounding factors in the Cox regression model, we found that just the prediction, so the high risk for development type 2 diabetes was tightly associated, 50% increase the risk of development forthcoming MACE. Next, please. So again, pre-diabetic condition can predict cardiovascular diseases. Next. What about type 2 diabetes? Next. This is a large meta-analysis published some years ago, including more than 100 studies and up to 90,000 people. Next. Showing that indeed diabetes is associated up to 5-fold, from 3 to 5-fold increase the risk of ED. Next. So diabetes is associated with 3 to 5-fold increase the risk of ED. Next. This is a paper, a study that we published some years ago by looking at people with newly diagnosed, so recently diagnosed, less than 2 years, type 2 diabetes among 27 Italian centers. Next. And in line to what reported in the meta-analysis, we found that almost half of them reported erectile dysfunction, and the vast majority of them decided to be included in the study. Next. And as already said by the previous speaker, as you can see, several psychological conditions as well as organic conditions were associated with moderate to severe ED in this population. Reduction of sexual desire, premature ejaculation, depressive symptoms as detected by CES depressive score, chronic complication of diabetes, and use of some drugs such as beta blockers in this case. Next. In this meta-analysis, we also found that especially in those studies, including people seeking medical care for erectile dysfunction, type 2 diabetes is associated with a reduction of circulating total testosterone up to 5 nanomolar in the population of people with erectile dysfunction. Next. These are data coming from general population European Malaysian study, a multi-center population study including more than 3,400 people, and looking at the prevalence of secondary hypogonadism and primary hypogonadism in the general population, about 11% and about 2%. Next. When we look at the same cutoff in people seeking medical care for ED, the prevalence of secondary hypogonadism go up to 26 to 6% and primary hypogonadism 4%, so almost 3 times higher. Next. Especially for secondary hypogonadism, and when we look at the calculated free testosterone, again 33%, and again primary hypogonadism quite similar, 4.6%. Next. So a combination of organic and psychological factors for sure underlines type 2 diabetes associated erectile dysfunction. Next. Sorry, the previous one. Also, the previous one. Also, that's fine, no problem. So also the presence of ED in a subject with diabetes, there was a meta-analysis in the previous one, is again, so the presence of erectile dysfunction should alert the clinician because it's a sign of forthcoming cardiovascular events. Next. It is also important to emphasize that the use of common drugs used for the treatment of ED works worse in this population. This is a meta-analysis. Again, next, please. As you can see, the higher proportion of diabetes in the population, the lower effect of PDE5 inhibitors regarding GIQ questions. Essentially, does these drugs improve sexual function and also score of IIF, so erectile function domain score. Next, please. So the higher proportion of diabetes, the lower PDE5 outcomes. Next. Also, the effect of testosterone replacement therapy is limited in this population. These are data coming from a recent meta-analysis that we published considering overall erectile function. Next, and also by evaluating only those studies using IIF as outcomes. Next. So again, even the use of TRT is limited. Next. So how to manage the problem? Next. This is a follow-up of our study. Next. After 2 years, essentially, we found an overall improvement in erectile function in phase 2 of about 30%. Next. And essentially, we found that the improvement of glycometabolic profile, glycated hemoglobin, lipid profile, uric acid was associated, tightly associated, even after the correction for confounding factors, with the improvement of ED itself, as well as ED-associated depressive symptoms. Next. So essentially, the improvement, just the improvement of metabolic control can ameliorate erectile dysfunction. Next. So essentially, my take-home message, my conclusion, for sure, we can say that not only established diabetes, but even pre-diabetic condition are tightly associated with arteriogenic ED, with reduced T levels, and also ED in this condition should alert the clinician since is a risk factor for forthcoming major adverse cardiovascular events. So the role of PDE5 inhibitors and TRT in this population is limited. Probably the combination of lifestyle, disease optimization, and medical treatment should be the best option, leaving surgical treatment even only when this kind of approach cannot work. And I thank you for your attention.
Well, thank you very much, Dr. Corona. That was outstanding, and I think there was a lot of good information there. Let us move forward with the Q&A, question and answers component of our program. Please submit your questions using the Q&A button rather than the chat. The chat is where we're having conversations, but I want to make sure we're clear about getting questions answered that you have out there among the participants. So please use the Q&A button and direct your question to the person that we should get the answer to. There is a question here, Lillian, maybe, or Annamaria, maybe you can help with this. Are the slides going to be available here? Just to put that up front there, that was a question. Do we know?
The webinar is being recorded, and the recording of the webinar will be made available from tomorrow onwards on the ISSM University and the ISSM website. Okay,
thank you very much. That's clear right from the start then. All right, so I think we have a question here for Dr. Vicente. Can PDE5 inhibitors increase the blood flow of the vagina?
This is a good question. For me, at least, I was smiling because I was not thinking about this question for a long time. But when there was the introduction and the studies on sildenafil, by time 2000, it was Viagra. It seemed that for men it was obviously very good. It was not so good for men with diabetes because the sensibility to response to this medication was less, and for women it showed no results. And remember, I was speaking that although these women that, and I was smiling because in 2000 or before 2000, I was believing that this question was a good question. We could help women with diabetes. But then we had the results that although you can change the patterns of vaginal blood flow and clitoral sensitivity, it doesn't change what women subjectively find about their arousal. So there is a poor correlation between biological factors and biological alteration and what women do feel like. And so some years later, the pharmaceutical just let down these studies, and never since then someone spoke or made any study on this because it is ineffective.
If I may add something to what Lisa told, which is very important, we have studies who show that PDE5 inhibitors in female improve desire and arousals in case of use of SSRIs or after spinal cord injury. The problem is that, like Lisa said, if you don't have desire and engage in sexual activity, the PDE5 will not work. So it's very difficult to measure.
Thank you for that clarification. Let me move on to another question. This has to do with psychoeducation. And for the conversation that perhaps Dr. Vicente and perhaps as well Dr. Reisman may answer to this, for type 1 diabetes management, in terms of giving psychoeducation, do you do that to, I guess, as I try to read this question, to inform people about type 1 diabetes? What do you mean by psychoeducation? Maybe it's just a more general statement, and appreciate your thoughts. Maybe Dr. Reisman start.
Psychoeducation is actually part of a very good question to clarify. Psychoeducation is part of our treatment on sexual medicine and sexuality in general, because we are not diabetologists, and actually we see the patient already with diagnosis, or we find a diagnosis because of the sexual problem. And in that case, our role is to psychoeducate them on their lifestyle, on their engagement in sexuality, answer the questions, and this part of it. And the psychoeducation is also about the relationship between confidence, self-image, all the issues that are connected to our sexual activities.
Can I add a comment? Sorry. No, I'm sorry, Lisa. Psychoeducation, I think I'm a psychiatrist. It's something you use quite a lot in psychiatry, this term, because it's about how does your disease have an impact on your life? I mean, how is the interaction between the psychological factors, the way you live your life, your emotions, and your disease, and also your physical health. So I think it's something that, as far as I know, comes from psychiatry, where we have a lot of education of people in how to live with their the disease they have. Sorry, Lisa.
Yeah, and for me, it's very important because women, I don't know about men, I know less, but I study women, I listen to women, but women don't know about their bodies, because I think that most of the times we begin our life without a book of instructions. You have a very small one, and then you don't have how, for instance, women don't know about their vulva. They don't say vulva. They also always say vagina. They don't have that. They have a clitoris with that extension. They don't know what means arousal. And so here in Portuguese Diabetic Association, I do a lot of work with the youth group. I make meetings, I make webinars, then I write on the magazine, because some people do want to know sometimes they don't know where to look for the good information, because nowadays you have a lot of information, but sometimes you don't know what is good information. And what I see is many difficulties, and I'm not speaking about dysfunction, many difficulties in sexuality are based on misconception, misinformation about the body, and sexual expectations. You should achieve something, and you should achieve in some seconds, and you should do it twice, 3 times on a roll. And so sometimes it's very important to give the correct information so you don't have all these problems in living with your sexuality.
Great, thank you.
If I can
Yes.
add a short comment, I'm
Sure.
a diabetologist, so I think we should educate not just the people, but also the physician, because many diabetologists ignore sexuality. And as we have heard, this is a very important problem for, especially for young people, but also obviously for people with type 2 diabetes, since CD can be a sign for common cardiovascular disease. So for sure, we need to inform and to educate also the physician, not just the patients.
Oh, very important comment. Another question, I think, Dr. Corona, you can maybe give a thought to this, given your good scientific work. The question here has to do with somebody with diabetes. What would be considered a healthy hemoglobin A1C for sexual health? And you talked about pre-diabetes and different cutoffs there. What give us some general thoughts surrounding that point?
Yeah, I mean, the diagnosis of diabetes concerning the glycated hemoglobin is 48 millimolar per molar. So if you have glycated hemoglobin above this cutoff with fasting glucose higher than 126 milligram per deciliter, this means a diagnosis of diabetes. So for sure, the lower level of glycated hemoglobin, the better is. But we need, especially for type 1 diabetes, we need to think about that very low levels can underline high frequencies of hypoglycemic events. So this is not the case. So my suggestion, and especially the current guidelines, should emphasize that higher level of glycated hemoglobin can be enough in people with a lot of comorbidities, because by obtaining very strong control can increase the incidence of hypoglycemic events, so the possibility of falls and the possibility of even cardiovascular disease. So it depends on age. For sure, around, I mean, less than 15 millimolar per molar is quite good for young people. From 50 to 60 is quite for middle-aged men. Even around 60 is enough for people older than, 70 and so on.
Terrific, thank you. This presentation is all about practical information, and a practical question here, and this is for any of the speakers. Do you recommend any vitamins or supplements to assist? And there's the questioner says there's been use of pycnogenol for women. So thought on that as well. So maybe Lisa will start, and then the others can chime in briefly.
I didn't understand what was the vitamin for women.
Pycnogenol, pycnogenol is what I read here. I'm not familiar with it myself.
I'm going to, because there are a lot of questions. Prasterona, something?
What?
Use. Papaverina, it's not for me.
So, but
yes. While she's thinking about it, yes, go ahead, Giovanni.
Yeah, just if I can add a comment. So the problem is that if we think in a scientific point of view, or if we think in economic point of view. If we think in economic point of view and in market, the market is huge and great. I don't
Indeed.
know, Kobe, if you agree, considering scientifically point of view is nothing. So especially the use of flavonoids for menopausal symptoms, there are no strong scientific data supporting the use of flavonoids. And if there are contraindications for the use of estrogens and for the use of hormonal replacement therapy, the contraindications are similar, because essentially flavonoids works on estrogens receptors.
Exactly. So we don't have scientific data. The only thing that I can say as urologist is that if female have recurrent urinary tract infection, and you know it bad as well, we need to decrease the pH of the urine, and you can use vitamin C in high doses. This is the only thing that we know from the science, let's say. But from sexual point of view, connected to diabetes, we don't have any scientific evidence.
So no, I have no vitamins that I give to women with diabetes. We were speaking about, I didn't spoke about women with menopause, because women get older and they approach menopause, and then as treatment for the symptoms, if they have symptoms, I do treat. I must pay attention for the risk factors. Is there hypertension? It's any risk of thromboembolism, any risk of cancer, because this is a democratic disease. You can have it all. And then I can treat women with diabetes. And on the contrary, that most people say, women with more risk factors with cardiovascular disease or risk for cardiovascular disease are the best ones, the best candidates for treatment of menopause, therapeutical for the hormonal therapeutic, because it decreases the risk of cardiovascular events. So it's quite on the opposite. You must tailor the medication, but they can have it. But fertile age, the only occurs me, the only vitamin that I give actively is acid folic when they want to be pregnant. And that was an issue that, of course, I didn't spoke today, but the biggest problem for me as a gynecologist and obstetrician is almost only a third of women who get pregnant and have diabetes have done preconception treatment and get a good control, metabolic control before pregnancy.
Terrific. Well, I think we're toward the end of the time that we were allotted. I'd like to conclude the session at this moment. Please know that more questions that you may have, please forward them. As we had earlier stated, the speakers are all glad to respond. I'd like to turn the program back over to Annamaria at this time.
Thank you so much, Bud. Can I have the slides, Lillian? First of all, I would like to thank you, the panel, and Bud. I think this has been an excellent session, and thank you for sharing all your knowledge and having like the different perspective. Like, this is what we really would like to do when we talk about sexual health, that we have so many different, both biological and psychological perspectives on it. So thank you so much for being here and sharing all your knowledge. And thank you, Bud, for running this always very well. And I'm, as you said, if there are questions that haven't been answered, please forward them to Lillian. And the speakers has kindly said they will get back to you and respond to your questions. So thank you for being here. I can tell you that we have had people from all over the world, from Uruguay to Botswana to Mongolia to Hungary to India to the North America. So it's always so wonderful to see all the greetings from all over the world. And I just want to advertise our next webinar, which will be about something completely different too, the hyperactive pelvic floor. What about it? So please put it in your calendar, and I hope to see you next time, and have a safe evening, morning, day, wherever you are. And thank you to everyone for being here. It's been such a pleasure.